Okay. Good afternoon, everyone. Today, we've got a guest lecture given by Dr. Rendani Tshikosi, who's based in South Africa and is a reproductive medicine specialist. I've known Dr. Tshikosi for the past 3 years, getting to 4 years now, and I consider him my South African brother. He's passionate about reproductive medicine, and he's also passionate about Zimbabwe. He has indicated that he's very eager once the COVID pandemic has receded to come and share with us his knowledge. So I feel honored and privileged to introduce Dr. Tshikosi and allows him to talk to us about Workup for infertility. Over to you, Dr. Tshikosi. At the end of your talk, I think we'll open up the floor and people will ask some questions. I'll be co-hosting with Dr. Mateveke, who's our Secretary General, and we'll be sort of like it will be the two of us will take over once it gets to question time. Over to you, Dr. Tshikosi.
Thank you, good Dr. Guja. Good afternoon, everyone. My name is Dr. Tshikosi, has been introduced. Please forgive me for last week. We had load shedding, and there was a problem with connectivity because our Wi-Fi was down because of load shedding. I'm just going to present about a Workup of infertility patient just for today, how to wake up patient for infertility. I'm a reproductive medicine specialist based in Cape Town. Why is it not going? Sorry. I just opened up a clinic in Cape Town called Fertility and Women's Health Clinic. That's my own clinic. I'm just starting. It's still in a beginner stage. The whole point is that the aim of this presentation, why do we see this patient? Why do we see fertility patients? And when do we see them? And how do we treat them? Those are the most important questions when we see this patient. Before I discuss the three things, I would just want to go through simple definition of infertility. What is the definition for fertility? The definition for fertility is the ability to produce a child, which means that if you can't produce a child, you're called that you're infertile. Now, infertility is the inability to conceive after 1 year of sexual intercourse. It needs to be adequate sexual intercourse, which is described as 2 to 3 times coitus per week. In a woman who is above 35, we use 6 months. Why is that the case? It's because there's a study which was done in about 121 women looking at fecundability, which is the ability to fall pregnant after 1 month. And they found that in the mid-20s, that's where women have their highest fecundability, which is about 20 to 25%. And that, when you're in the late 30s, it decreased by half, which means that after 35, you will use 6 months to start investigating. Primary and secondary infertility, I think that will be obvious to everyone. And then fecundity is the ability to have a live birth after 1 cycle of menstruation. Why do we see this patient? We see this patient, one, because we want to investigate why they can't conceive. Our investigation needs to be prognostic approach. It needs to be affordable to patient. We need to avoid exploiting patient, like doing unnecessary laparoscopy and unnecessary investigation. You need to find out what are you looking for. And all we're trying to achieve is that we're trying to achieve them to fall pregnant, whether naturally or not. Treatment, we need to treat early. If you can't find the cause, don't stay with the patient forever. You need to refer early. The ability to, we know that women have more chances of falling pregnant after their first exposure to sperm, which means your first month of exposure to sperm, you have high chance of falling pregnant. Your first 3 months are very high of you to conceive. Now, 60% of women will conceive on their first 6 months of attempting to conceive, and then 80% of them will conceive on their first year. And after 2 years, only about 90%, and that figure doesn't go up afterwards. We also need to ask women about window period. This is more common to women who are not having regular intercourse. There's a study done to look at people who are having coitus every day, people who are having alternative coitus, and people who are having coitus once a week. And they found that the chances of you conceiving after having coitus every day is about 38%. And if you're having alternative days, it's about 35%. And if you're having coitus once a week, the chance of conceiving is about 15%, which means that for those who are having coitus irregularly, the chance of conceiving are almost less than half. Now, these things of measuring the window period is important for those who are not having regular period. You can have a direct method of measuring it, which you look at the ultrasound, you do a follicular tracking on the woman, then you look at the follicular rupture, and you can also see the fluid in the pouch of Douglas. The indirect method, you can do bloods. LH, you're looking at doubling of LH, which means you do an LH tracking. When the LH is doubling, then you know that the woman is always ovulating. Your progesterone can also increase to about 10. You can buy an LH kit. This is expensive. It's a urine test which women dips inside, and they look at, they to tell them when is the right time to ovulate. Cervical mucus score and basal body temperature, those we don't do it anymore. The PEL kit is the new kit which has just been produced by another company where it look at both estrogen, LH, and progesterone. It tells you all parameters, and that kit you can do it every day, which means you don't have to look at your menstrual calendar. You just depend it every day. In South African rands, that costs about 750, which is the high cost to women. But those things are for people who are not having coitus every day, as I said. Endometrial biopsy, we don't do this, very controversial. We are looking at a secretory progesterone. Those are the kind of tests we don't do. Progesterone, the moment you're doing progesterone tests, you just want to confirm if ovulation have happened, which means that if you look at the progesterone about 3 nanogram per mil, if the progesterone is more than 3 nanogram per mil, especially for the patient, maybe you're calling that they have ovulation dysfunction, then you know that it needs to be in that level. When you look at the cause of infertility, the male and female infertility counts about 60%. In South Africa and in the community I work with, you find that tubal factor infertility in terms of female is about 41%, which means that's the biggest cause in our country. And you also have 25% of people who both male and female are fine. There's nothing wrong with them and they're not falling pregnant. Treatment of choice can be ovulation induction with artificial insemination. The chances of improving of pregnancy with ovulation induction and artificial insemination looking about 9 to 12%. It can either be combined causes or others. The basic evaluation of this patient start with the basic medical history. Same we studied in undergraduate. You need to do an intensive history. The period of infertility is important. Their obstetric history is important. You need to find out about their menstrual history, their surgical history, because addition can also cause infertility. And then you need to find out about coitus history. How often do they have coitus? As I just explained, what is adequate coitus? And if they use any lubricant, because most lubricant have found out to affect the sperm, which means you need to ask about lubricant, and if they understand the window of infertility, the window of opportunity where they are most ovulating, because we know that if you're ovulating 24 hours before ovulation and 72 hours post that, that's where you're more likely to conceive. Genetic history is important to those people with genetic abnormalities. History of recurrent pregnancy loss is also important. Other tests you can do is decrease of ovarian reserve. According to the fertility sterility, you only do decrease of ovarian reserve in women above 35. We know the postident talk about the women who are below 35, but in our community, we do decrease of ovarian reserve test in women who are above 35 unless otherwise indicated, which means it's a patient you are suspecting that they have decreased ovarian reserve, previous multiple cystectomies, patient with endometriosis. Those are the patients you can do decrease of ovarian reserve test. And I'll speak about those tests, which tests are they. And then ovulatory dysfunction, you're looking at the 80% of women with ovulatory dysfunction are due to PCOS. But those without PCOS, which means that your Clomid and your Femara doesn't work, which means that you need to diagnose PCOS according to Rotterdam criteria for you to treat patient with ovulation induction with Femara and Clomid. Otherwise, if the patient have other pituitary or hypothalamus causes, those don't work. The other cause of ovulatory dysfunction is premature ovarian failure and hyperprolactinemia. We'll talk about tubal assessment tests and also the evaluation of the uterus. This I've spoken about, that you Your history, your BMI is important, your secondary casual characteristics, looking at your excessive hair, and then your epididymis nigra, and a complete gynae history, which includes ultrasound, and retrovaginal for those who suspect that they have adnexal masses or they have an endometriotic nodule. In the male side, as we said, the couple need to be treated by one person. You need to find out history of previous moms, history of previous undistended testicle and surgeries. You need to find out the lifestyle evaluation, whether they smoke, they drink, using of illicit drugs, which also decrease infertility and severe obesity. Coitus, people with chronic medical condition like diabetes, them if they have any erectile dysfunction, any premature ejaculation, and the semen analysis using the Cooper in the 2010 model. We're no longer using the strict Tuckerberg criteria now, we're using the Cooper, which you look at the volume of 1.25, you look at the total mortality, the forward progression, and morphology of 4%. I just put the slide to just show now we're using the Cooper, which is 2010 by World Health Organization by Cooper. The blood test. Progesterone test is only important for those people that are suspecting that they are ovulatory. If the patient have regular intercourse and they have sign of melamina, there's no need for you to do a progesterone test. You can just assume that those people are ovulatory. In terms of ovarian reserve test, there are two tests, AMH. AMH needs to be more than 1.1, and your antral follicle count needs to be more than 7. Anything between 5 and 7 is low. Your FSH needs to be less than 10. The standard for both male and female, they all need to do your HIV test and your rubella. So the HIV test and the IPR, the rubella is only for female. You need to look at rubella if they're immunized, and the pap smear for females. There's, the basic test, fallopian tube test, there are a lot of tests which you can do fallopian tube tests. We still advocate for HSG, even though most doctors have moved to laparoscopy and chromopetubation. Why? It's affordable, it's cheap. We know the side effect of it is that it's very painful and uncomfortable to women. But we know that it's a bad test in order to assess uterine cavity. But in terms of tubal tests, there's about sensitivity of about 88%, which means a good test to do to assess the tubes. And let's not forget, oil-based HSG can improve your pregnancy rate by 3 to 5% in those who had blocked tube. Other tests which people are using nowadays is hysterosuspinal contrast sonography, where they mix the fluid they mix the fluid and with the cell line and they inject it. And that is a good assessment for the cavity, and you look at the bubbles going through the tubes, and when you can track the bubble with an ultrasound. It's also the same if you're using foam, that's kind of the same thing. One thing which people speak about, but I've never seen it being practiced, is the fallonoscopy. And they say this is better for people with corneal blockage. And for those with corneal blockage, there's about 85% of treatment. Yes, there's a reocclusion rate of about 1%, but there's 50% pregnancy rate. I've heard about people talking a lot, but I've never seen it being practiced. But they said for those people you can't cannulate, you suspect that they've suspingitis aethnic-nodosa or chronic suspingitis or fibrosis, which means that microsurgery is not indicated in those patients. Patient needs to go straight for IVF. Chromopetubation is the gold standard for assessing your tubal assessment. And if you're going to do a chromopetubation in patient of infertility, always do a hysteroscopy. Always book that patient for hysteroscopy because you're already in theater, because the gold standard of assessing uterine cavity is hysteroscopy. Now do hysteroscopy and add your chromopetubation. Chlamydia test, we know that the sensitivity is very poor. It's about 40%, and there's high false positive because of chlamydia pneumonia. We don't do that test at all in our setting. That's a picture of showing that HSG, with the first slide is patient with bilateral hydrosuspinges. The effect of hydrosuspinges is that it has effect on pregnancy. I mean, in this patient, you need to look at if they have bilateral hydrosuspinges, Nowadays, people are advocating that there's no space to remove women's tubes. Please open the tube, remove the fluid. Because what is toxic to the pregnancy is the fluid, which leaks inside. It decreases receptivity, and it also toxic to the embryo. But there's advocate nowadays that don't remove women's tube. This is the one which I'm just showing the picture of how people do stereosuspingeal contrast sonography, where you inject the fluid and you track the bubbles through the fallopian tube. If you're doing laparoscopy, you need to grade so that when you refer a patient to another person, they know what kind of tubes did you see. Now, the standard grading which you have is there are so many of them. The Hall and Rutherford classification, the one which has been there for some time, which means you look at whether it's proximal or distal blockage, what was the mucosal layer, and the type of adhesion. Now, it's always better when you finish doing your history or your laparoscopy and chromoperturbation, just give us the grading of your tubal assessment. And then you just write it down on your referral notes because you're already there. Just a completeness of assessment. The uterus evaluation. Congenital uterine abnormality, there's a lot of controversies about that. Does uterus abnormality cause infertility? That's the biggest question. We know that uterine anomaly can cause recurrent pregnancy loss, can cause preterm labor, but the Cochrane review in 2017 just show that they say there's no space for hysteroscopy and metroplasty in infertile patient in that case. But in terms of patient with recurrent pregnancy loss, in case of patient with preterm labor, there is space for metroplasty in those patients. Polyps will affect the receptivity of the pregnancy. In terms of intrauterine adhesion, one of the most common one is Ashman syndrome. Unfortunately, there's no consensus about the classification of Ashman syndrome and the treatment. We know that the gold standard of diagnosing it is hysteroscopy. Treatment can either is trying to remove the adhesion. It can either by a scissor. It can either use energy sources or laser. Post-treatment, other people can put anti-adhesive things inside. They can put the space for stem cells, PRPs, IUCD, high dose of estrogen, the vaginal sildenafil, aspirin. There's no consensus about treatment, but the basic thing is that post-treatment, 6 weeks post-treatment of Ashman syndrome, risk of the patient, look at adhesion if they're still there. In terms of fibroid, the size matters, the numbers, but in terms of the type, we know that 0, 1, and 2 affect fertility. There's a huge controversy about fibroid in terms of 3 and 4. Those are your intramural fibroid. Sankara showed that some fibroid, which are intramural fibroid, decrease ART. Then Oliveira also showed that fibroid which are more than 4 centimeters also decrease pregnancy rate. And if you look at the Italian guy like Somilia, also he said the fibroid below less than 5 have no effect. I mean, now we have the Chinese guy called Yang, who saw that fibroid which are less than 2.8 also decrease fertility. But it's all about the endometrial myometrial junction, which means fibroid which affect the endometrial myometrial junction have effect on fertility. That's the take-home message. And the one thing I want to talk about is isthmosil. Isthmosil is the anterior scar of the previous Caesar. It's a very common thing. The prevalence rate is about 19 to 88%. It causes infertility and is found in most infertile patients. With the previous Caesar. What are the risk factors? In risk factors, you can either have non-modifiable risk factors, you can have modifiable risk factors, and you can have surgical risk factors. In terms of non-modifiable risk factors, you're looking at the patient who are less than 30 years of age with a retroverted uterus. In terms of labor risk factors, you're looking at a patient who's been more than 5 centimeters dilated, prolonged labor more than 5 hours, they have low station, and patient with previous multiple cesarean section. In terms of surgical risk factors, you're looking at a patient who had only one layer closure of the uterus, they have locking stitch, and who have the cut which is closer to the internal os. Most patients are asymptomatic, and those who have symptoms, about 75% of them present with abnormal uterine bleeding, 50% of them have dysmenorrhea. Because of the accumulation of fluid in the scarring of the uterus, that affects the receptivity of the endometrium receptivity and also affects cervical mucus, which become hostile to the sperm. The diagnosis, you can diagnose it by ultrasound, but the gold standard diagnosis is hysteroscopy. Now, when you put a hysteroscopy in a patient with a previous Caesar, always look for the scar. Most of the time you will find it. Effect of treatment. The medical treatment for those patients it affects fertility, which is either your condyciosis or your Mirena, which means that is not for patients who want to be fertile. And in terms of surgical treatment, you can either do a transvaginal approach, a hysteroscopy approach if the myometrial thickness is more than 3 millimeters. If it's less, you can do a laparoscopic approach. The outcome of pregnancy in laparoscopy approach was about 99% by Dozen. The vaginal approach was done by a guy called Zhang, and he showed that there was 93% success rate in those cases. Evaluation of the uterine cavity. Saline infusion sonography is one of the best things with good sensitivity. You can just put small catheter inside the uterus, push normal saline. Other people are saying you can also, when you do that, if you find that there's fluid in the pouch of Douglas, which may just give you an indication there's a patent tube, but it's not one of the tests to assess tubal function. But if you're doing a saline infusion sonography in a patient, if you're looking for abnormality of the uterine cavity and you find that there's an accumulation of fluid in the pouch of Douglas, it just gives you that sense that there is one patent tube. 3D ultrasound and MRI, they have the same outcome. There's nothing which is superior to the other one. And I said the gold standard is hysteroscopy. I just mentioned that before. These are just pictures which are showing patient with a saline infusion. You can see the polyp coming out easily because the uterus is full of fluid. These are the patient with Asherman in an HSG. And this is the 3D ultrasound, which is giving us different type of uterine anomalies. Cervical factors is something we don't practice anymore, which in postcoital tests, we don't do it anymore. It's done for those patients who can't produce sperm, which means the patient fail to produce sperm, they go and have coitus at home. Within an hour, they come back, you look at the cervix, you aspirate the cervical mucus, you look at if there's a live sperm. Nowadays, there are artificial things which you can stimulate the man to produce sperm, but this is also one of the things, but we don't do cervical assessment in terms of cause of infertility. Peritoneal factor. The biggest thing I want to talk about is endometriosis, which we know that 20 to 50% of the patients with endometriosis are infertile. And we also know that the fecundability of endometriosis is about 2 to 10% compared to 20 to 25%. We know that there's a reasonable evidence that demonstrates that endometriosis decreases fertility, but there's no obvious causal between the two how it causes infertility. Now, it's very important to assess patients with the endometriosis because the first surgery of endometriosis is the best surgery for those patients, which means we need to assess those patients with the endometriosis. The gold standard of diagnosis is laparoscopy and biopsy, according to American Society of Reproductive Medicine. The treatment of stage 1 and 2 endometriosis is ovulation induction and artificial insemination. Other people are saying the outcome of ovulation induction and artificial insemination is almost the same. as no treatment, but we know that there's about 9% to 12% increment. In terms of stage 3 and 4 endometriosis, those patients, we know that treatment is important in good hands, and I'll speak about it later. But the other issue I want to talk about is endometriomas. What do you do with patient endometriomas? The advocacy of going after the endometrioma more than 3 centimeters with the pain is only with the Canadian College of Obstetrics and Gynecology. People need to be aware that every time you go and operate an endometrioma, you decrease ovarian reserve. And their studies show that the first operation of doing an endometrioma surgery, there's a 25% decrease of ovarian reserve. If there's bilateral endometrioma, there's about 45 to 50% chances of decrease in ovarian reserve. The treatment of endometrioma, whether you're going to aspirate it and ablate plus minus ablation, whether you're going to do a cystectomy or you're going to do a 3-step process where you aspirate, you give a generalized analog and go again and do cystectomy. There's no one which is superior to the other one. But Ashray said cystectomy, cystectomy is better because it has decreased the recurrence rate. Someone spoke, I don't know. For patients with previous surgery, previous seizures, and your previous ruptured appendix, you need to do laparoscopy to just exclude adhesion molecules. So to exclude adhesion and tubal disease. As I said, laparoscopy is not recommended as a routine procedure only. Tests not routinely done, as I said, laparoscopy for unexplained infertility, advanced sperm function test. I mean, if you look at DNA fragmentation, there's not even a treatment for DNA fragmentation. I mean, there's a study which came out this year around February, which spoke about antioxidant, zinc, and vitamin E in terms of treatment of sperm fragmentation. There was found that there was no difference in terms of prognosis. Post-coitus tests as for those men who couldn't produce sperm. Thrombophilia and immunological testing are for patients with recurrent pregnancy loss. Karyotyping when it's indicated, and endometrial biopsy, as I said, is very controversial. For patients with galactoria, it's only those patients you can look at prolactin levels. Patients you need to urgently refer to the reproductive unit are patients who are about 40 years of age, men with previous history of subfertility, patients with deep infiltrative endometriosis, patients who are going for cancer treatment or post-cancer treatment who want to conceive, and those who have diagnosed the disease, either tubal disease or uterine disease. That's the conclusion of my presentation. I'll take questions. You only need 3 to 4 things to fall pregnant. You only need sperm for regular sexual intercourse. You need your open tubes because your sperm and your egg meet on the tubes. You need to be ovulating and to produce follicles. That's all you need to be pregnant. But the take-home message for me is that the time to pregnancy is not well defined. It's not well defined how long should you sit with the patient before you refer them. But it has been shown that those patients who conceive early are much happier. If you go and look at PGT, in terms of not doing PGT, in terms of testing the embryos, we've seen that the only thing it does is to decrease time to pregnancy because those embryos, if they were frozen, they're going to be transferred anyway. Now, it's very important to expedite treatment and enhance the ability for patients to conceive and refer when necessary. Thank you very much, and I'll take questions.
Okay, thank you very much, Dr. Tshikosi, for the very informative talk. I think I would want to say I personally I've learned a lot from what you have just taught us. I will now open the floor for some questions, but since I have the floor already, I'll ask some questions that I have. You mentioned that the lubricants use of lubricants might affect sperm function. Is it both water-based and oil-based lubricants, or is just the oil-based lubricants?
They've looked at in terms of water-based. I forgot the name. There's a study which look at both water-based and oil-based and your KY jellies, and they found that it had some effect. There's only one lubricant which they found that it didn't have any effect. I forgot the name of it. I'll be lying to you, Dr. Guja. But it's always better to avoid such.
Okay, and you say that now the recommendation is to leave the tube behind. So
Yes.
I'd want to know why is there be a change in the recommendations. Looking from an oncology point of view, we now know that high grade serous ovarian cancer originates from the fallopian tubes. So looking at it from that perspective, would then probably recommend that if the tubes are not going to be working anyway, probably should take them off and reduce the risk of the woman getting ovarian cancer later in life.
Yeah, I just want these are the patient with the hydrosuspinges, which means that you're looking at the dilatation. If the patient has suspingitis nodosa, it means that the whole tube entirely is diseased. You need to remove it. I'm talking about in patient with very dilated tube, which are more than 2 centimeters. You can just do a suspingostomy and leave them behind, because no one have done a study to check if those tubes will refunction in the future. We know that there are high chances of them occluding again, but we don't know if they will never function if you open them and there's patency. I'm talking about the tube which you can open and leave them patent, which
Okay.
means that if there's a tube where you can put dye and you see that there's a corneal blockage and then there's a hydrosuspinges, that even tube doesn't even affect pregnancy. So for you to also go and say, I want to go and do a hydrosuspinges surgery, the diagnosis is on ultrasound. It's not an HSG. You need to be visualizing those hydrosuspinges tubes on ultrasound.
Okay, then my last question is, I saw one. I know you didn't touch on management. I
Yeah.
saw a patient with recurrent miscarriages, who was being seen by a reproductive medicine specialist down in South Africa, and they were offering a pre-implantation genetic diagnosis and IVF. I want to just quiz you a little bit on that. Would that be standard care to refer a patient with recurrent miscarriages to a reproductive medicine specialist? And if there are any studies that have been done to show that doing pre-implantation genetic diagnostic tests we improve, we sort of like we improve pregnancy outcomes in someone with recurrent miscarriages?
No, it wouldn't at all. Remember that, as I said in the presentation, that PGT, you're just doing it to check if the embryo you're gonna transfer is the beta blastocyst, and you remove those you're not gonna transfer. If this woman produce, for example, 8 blastocysts, in terms of we don't do PGT in a public hospital, we're gonna freeze. Let's just say you're gonna freeze 6, and then you're gonna transfer 2. At the end of the day, all those embryos will end up in the abdomen, which means whether it's gonna catch and continue to lifetime pregnancy or not, no. PGT doesn't increase pregnancy outcome. It just reduces the time to pregnancy, that the best embryo is the one you're gonna transfer first.
Okay, thanks so much. Course, we've got a question here from Dr. Muyocha, who is asking, so do you recommend routine anti-Mullerian hormone testing, or you recommend using testing it based on age?
I mean, according to Sandra's in the fertility and sterility, they said it needs to be based on age, unless indicated, which means that if you have a patient that you suspect that they have poor ovarian reserve, in that patient you can do it. Patient with previous multiple cystectomy, previous ovarian surgery, patient with endometriosis, those are the patients you can do AMH on. But before then, no, I don't recommend it.
Okay, thanks.
And remember that AMH doesn't affect pregnancy, it doesn't tell you the chance of woman conceiving, which means if a patient has AMH of less than 0.3, it doesn't mean that she can't conceive. It just means that she has poor ovarian reserve, which means it doesn't predict pregnancy.
Okay, thanks for that choice. Because I don't see any raised hands, so probably I'll open this to the floor. Dr. Mateveke. I don't see.
Yes, afternoon, Dr. Gusha. Dr. Tshikosi, thank you so much for the lovely presentation. And I was listening in quite very, very interesting and informative. I'll just, I'd not have any question for you at this point. I think representing our society as a Secretary General, I would say we are very happy to be collaborating with you from Cape Town, and we really look forward to more collaborations like this in future. Thank you so very, very much.
Thank you, thank you. I'm very honored to speak to the public in Zimbabwe. I'm very passionate about them. I'm Venda, we're just neighbors. I'm just in Cape Town.
You should consider relocating.
When the economy is better, I'll come.
Maybe just a quick one. Sorry?
I've been raising my hand. You missed it.
Oh, I'm sorry, Dr. Matsira. I didn't see it. Please, you can go ahead.
Thank you very much, Dr. Tshikosi. Very informative talk. I've got a quick question on isthmus. Are you doing routine hysteroscopy on all the women with a previous cesarean section scar if they present with infertility? Or maybe first do a transvaginal ultrasound scan, and then when you see any irregularities in the endometrium, that's when you proceed. And if you find it, what's the sort of modality you're doing if they have gotten obvious isthmus? How are you managing them?
Most of the time, if you find it and then the layer is still more than 3 millimeters, you can just shave it out. You can just shave it out on your hysteroscope. You can just shave it out and just level. It's just a dent in between your internal os and your cavity. Now you just want to level that platform to be flat. That's how you manage it.
Okay.
Only if it's very thin and the thing is it's very thin, then if you're either going vaginal or you're going laparoscopic, then you can suture. But for that, it's just to shave it off. You're just leveling the pot so that that blood and that endometrium doesn't accumulate there. Because if when you look at it, you'll find that most of the time, even though when you look at the endometrium and the woman is not in a period, there's always an accumulation of blood there and like in that scarring. Now you just shave it off.
So you're doing routine hysteroscopy on all those with a previous cesarean section scan?
No, we're not. I'm just saying that when you go to do a hysteroscopy in a patient, you just look out for it.
All right, okay.
Yes, you're just looking out for it because it's something which is coming out a lot now in papers. Now let's not forget that it's there and let's look out for it. Because then we're just interested on going in, actually, if you look at it previously, and we look at the ostia and look at the cavity and we're coming out. We're not really going to look for isthmus. Now the teaching is that let's look for it because it exists, it is there.
Okay, thank you.
Then Prof Mjanja is raising his hand. You can go ahead, Prof.
I can improve.
Prof Mjanja.
Can you hear me?
Yes,
Yes,
Prof.
I can hear you now. Please go ahead.
Prof just disappeared.
We can hear you, Prof. Please go ahead.
I think it's muted.
Prof, maybe unmute your mic and go ahead with your question.
It's okay. I'll type my request. It's fine.
No, we can hear you now. Please go ahead. We can hear you.
So we don't teach about adoption as a solution to infertility because of cultural issues. Is it any different in South Africa? Are the couples, the black couples, are they more willing to adopt children as a solution to infertility, or are they the same as in Zimbabwe?
I think they are the same. We still tell the patient about the option of adoption. But in terms of our African community, we find that women want to be seen in the community carrying the pregnancy. And that's the sad part about it, which means that option, I've been in a unit for like 2.5 years and 2 years of register time in the same unit. And I can tell you that I don't remember any case of someone saying, I'm done. The success rate of IVF is about 25% to 35% in the best lab. Even if people have done multiple cycles, I think the adoption is not one of their best options. I think it's casual, I'm not sure, but they're not really, people want to be seen carrying pregnancy and be known that they were pregnant.
Thank you.
Thank you, Prof. And then there's a question from Dr. Moyo in Bulawayo. He says, can you clarify on the statement on AMH of 0.3?
What do you mean? Okay. If you look at the Bologna criteria, when you talk about decrease of ovarian reserve, it tells you that the AMH is said 0.3 to 0.1 is low AMH. That's what I'm trying to say. Now, the lowest AMH you'll get, it will be, the last figure just says 0.3 and that's it. It doesn't say 0.0 whatever. I'm just saying that's the lowest measure in terms of AMH. Now, I'm talking about in terms of the Bologna criteria, looking at what is decrease of ovarian reserve. Yes, they look at women with above 40, and they also look at previous cycle of stimulation if patient produce less than less than 3 follicles. Now, AMH 0.3 is the lowest.
Dr. Madzira, I can thanks Dr. Tshikosi. Dr. Madzira, I can see your hand is raised. Do you want to ask another question?
No, sorry, I'd forgotten to lower it, but I just probably, since you mentioned the Bologna criteria, there's the potassium classification which says low is less than 1.2 nanograms. I don't know, can you comment, or does he have patients who is attending to who manage good pregnancy rate below 1.2 nanograms per mil of AMH?
As I said, yeah, less than 1.2 is still low. Now, if we see a patient and the AMH is less than 1.1, for us, that is low already. Now, if you look at Poseidon, when you look at 1.2 and 1.1, their reference range is not very bad. It's almost close, they're almost the same. But as I said, AMH doesn't predict pregnancy rate. It predicts follicular outcome. Now, we still see most patients with lower AMH going to have pregnancy, whether natural or by stimulation. You just know those patients. In terms of stimulation, you need high dose drugs. And then if you look at Poseidon, I'm just giving it a Poseidon. If you look at women who are given Poseidon, the conclusion there was saying that whether you give high dose drugs or low dose drugs, the outcome is the same. But the review of that showed that it's not the same, because women who were given high dose, the cancellation reason was because of risk of OHS. And the women who were given low dose, the cancellation rate was because of either they couldn't produce any follicles and there was a decrease of ovarian reserve. Now we know that high dose lead to more follicles. Now, AMH is not predictor of pregnancy, it's just a predictor of follicular outcome.
Okay, thanks, Dr. Tshikosi. Thanks, Dr. Madzire, for the question. Bismarck, I don't see any more raised hands. I don't see any questions.
No, this has been a wonderful presentation and very, very interactive. I think we managed to actually stick to time. So if we do not have any more contributions, maybe we can call the meeting to end. But we would want to employ on Dr. Tshikosi to finish what he started today, because I'm sure we'll still need to see him in the next 2-3 more sessions, talk about management of various causes of infertility, he just gave us a snippet of the workup for the fertility problems. So we implore on him to come back and finish what he started. Thank you very much, Dr. Tshikosi.
Thank you very much. I owe you that much. I'll come back.
Thank you.
So please keep your diary open for your Zimbabwean brothers.
I'll definitely do that.
All right, thank you.
Thank you, everyone.
Bye.
Dr. Guja,
Hi, Dr. Matsire.
can scientific committee members remain